Okay.
So, good evening, everyone. Welcome to the session number 69th of the Beyond Research series, which is a joint initiative by Biopractify and ACS student chapter of IIT Delhi, which aims to empower students and aspiring researchers in identifying their uh, career journeys through inspirational talks of speakers like our speaker today, Mr. Konduru Somanadh Ravi Teja, who is from IQVIA and is a clinical data specialist. So I'll give a brief introduction about you, sir. It gives us a great pleasure to welcome our speaker for today's session, Mr. Konduru Somnath Ravi Teja. Mr. Ravi Teja is a clinical data specialist at IQVIA with over 4 years of industry experience in clinical data management and biostatistics. He holds an MTech in bioinformatics from Shobit University, Uttar Pradesh, and has built a strong research and industry profile at the intersection of the clinical research in oncology and data driven healthcare. He has published 10 research papers in reputed journals and has worked extensively in diverse domains, including breast cancer bioinformatics, Alzheimer's disease, rheumatoid arthritis, uh, vaccine design, and stem cells. Just a second. Just a second. Sorry for the interruption. Yeah. He has worked in diverse domains, including breast cancer, bioinformatics, Alzheimer's disease, rheumatoid arthritis, vaccine design, and stem cell transplantation. His academic and research journeys include hands-on experience with mouse embryonic system stem cells at University of Hyderabad, as well as gene expression analysis of rheumatoid arthritis patients at IBAB Bengaluru. With a unique blend of clinical industry exposure and translational research experience, Mr. Ravi Teja brings valuable insights into how medical oncology is evolving and how modern therapies are shaping patient care. We are delighted to have you with us as a speaker today, sir, and we are delighted to have you share your expertise with us and through a session in overview of medical oncology and therapies. Welcome, sir. Over to you.
Yes, sir. Thank you for your invite and thank you for your introduction. So, hi everyone, and I am Ravi Teja, and I am currently working as a clinical data specialist in IQVIA. So, usually, like we will work on clinical trials activities in different domains like cardiology, oncology. But my areas of interest and my research is going in the field of oncology. So, because we have as mentioned that initially, so as Vinit mentioned that it was. Initially we worked in breast cancer and currently we are working on Alzheimer's and colorectal cancer. So these are all because oncology nowadays, why? Because like many things, it is the most cancer, most causing top five diseases. Cancer is one of the major diseases, not only in the particular country, it is through around the globe. So that's what it was. The medical oncology and therapies is also very important, like what type of therapy you are using and what type of treatment you are using. So these are all come under all these things. So medical oncology having lot of scope and future further things, because upcoming we are doing everyday activities like data activities and clinical trial activities, new things. So we got to know there are a lot of future for every these things. So can I let me share my screen, then I will start about the introduction of. You're able to see my screen, guys?
Yes, it is visible.
Yes. Yeah.
But
Yeah. Now you're.
yeah,
Yeah.
yes,
No.
it
Yeah.
is.
Now. Yeah. First, we have overview of medical oncology. So first of all, oncology, like just first of all, we need to say the cancer. First of all, what is the cancer? Cancer, see, by birth when we don't have a cancer or anything. So by birth when we born, we have some cancer cells, everything for cancer cells, diabetic cells, whatever everything will be there. But when the thing is pointed, when it got highly expressed, then only it will come into the picture. Everybody, even everyone has the cancer cells in the body. When it get highly expressed in the body, then it becomes that normal sensitive cancer cells. So first of all, see that cancer cells. Cancer is a disease characterized by uncontrollable growth of abnormal cells. Because see, when something happens, some mutations or modifications are happening in the cell or cellular level at genetic level, so immediately that particularly four cells get divided into the body. Then unfortunately normal cell became tumor cell, it become like 4 became 16, 16 became 32, it into 5 into 2 times it will get it divided. So as I mentioned earlier, so one of the most common cause of death is one of the top 5 diseases is cancer. We can call it as a cancer malignancy, because we have a tumors, because cancer is nothing but like when we have the cancer cell, we call it as a tumor. Tumor, we have a different two types of tumors. One is benign tumor, another one is malignancy tumor. So first of all, benign tumor is not a like it's a non-cancerous. Like when you feel stressed or anything, some type of small benign tumors will form in your body through neck or hand or on face. So these are all called benign tumors due to stress or due to pressure, or you feel somewhat uncomfort like during your some body health conditions. So benign tumors automatically everybody have the benign tumors on the body. So but coming to the malignancy is a completely a core cancerous things. So we go to this picture, we can clearly know that benign tumors, as it will be, see these are all the tumors, we can call it as benign as a tumor but not cancerous. So here the tumors, pink color the tumor cells in the benign. So but in malignancy it became double, but in the benign tumors it won't get it replicated or it get it duplicated. So it will be just in the normal, like 4 become 4 or that's it. But in malignancy it became more. So that's what like we need to focus on that how the malignancy, because from starting the from cell is dividing, so from benign to malignant. So what are the types of cancers? Because we have a lot of cancers are there: lung cancer, kidney, and liver, leukemia, like blood cancer, breast, prostate, and melanomas, colon and cervix cancer, and bone cancer. Like a number of cancers are there in the body, brain cancer. So these are all coming to the picture. So the whole body cancer will be there from each end of every organ. So these things, so because based on these cancers we have two types of tumors. Like cancer, I told you initially, cancer is nothing but the cancer cell, we call it as a tumor. Okay, in the tumor we are dividing the tumor into two types. First of all, it is called solid tumors, and another one is lymphomas. Means solid tumors is nothing but like we have abnormal masses of the tissues, like lining of the tissues or connecting tissues. So these guys will call it as a solid tumor, so which will be on the particular lining of the organs. So solid tumors are classified into two types. One is carcinoma, another one is sarcoma. Okay, carcinoma is a cancer arising from epithelial cells. Means that lining of the organs, lines of the organs, inside of the organs, lines which will be in the organs lining, epithelial lining. So there it will be called as an carcinoma. In that carcinoma again we have few different types. So adenocarcinoma, basal carcinoma, squamous carcinoma, ductal carcinoma. We have all these invasive carcinoma. So all these things which will be like different type of things. So here adenocarcinoma, if you can go through it, adenocarcinoma, these are all this cancer all coming into that, like forming in the organs lining, like epithelial lining. So here this adenocarcinoma is nothing but that was a eraser, means that cancer will form gland and line of the organs, major to the top of the line of the organs. That is called prostate cancer. We have breast cancer like that, and colorectal cancer. So, are you clear? This thing, I little bit I am going fast. Is it fine for everyone or how it is? Like, you people are getting understanding or how? Am I audible? Hello? 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 Am I audible? Okay. So, are you are getting my point that what I am saying? Hello?
Yes, you are audible.
Okay. I'm going little bit fast. Or you are getting my points that what I'm saying, right?
Yes, yes.
Yes. Okay. Okay. Yeah, please tell me. Hello.
They are like typing in chat, so I think you
Okay.
are not able to see the chat.
Yeah. Okay. Okay. Okay.
Participants, you can also unmute. You have the access if there is some need.
Yeah. Okay. Okay. Then we have a basal carcinoma. Basal carcinoma is nothing but regarding a type of skin cancer which can form the lowest layer of the skin, which can be down layer of the skin. So this is called like a, this is as well down layer, means lining that layer of the skin. That is called the carcinoma. So squamous cell carcinoma means the basic difference between squamous carcinoma and basal carcinoma is like basal carcinoma is the lowest layer, squamous carcinoma is the upper layer. Means upper layer means which the organs which is connecting with the skin, like top layer like ear, nose, neck, arms. So these are all the called as squamous carcinoma, because squamous carcinoma spread more faster than basal carcinoma because of the, you know what, like when the cancer tumor is spread in the body or formed in the body, it will take time to, like it will be spreader. But coming to squamous carcinoma, it is the upper layer, means then it will be exposed to the environment, it will be exported to the, you know, like infectious diseases. So that's why compared to basal carcinoma, squamous carcinoma is a bit faster than basal carcinoma because of that environmental factors, and you know, through outside viruses or infections or bacterial diseases or something, etc thing. So it will spread more than basal carcinoma. So ductal carcinoma. What is ductal carcinoma? Ductal carcinoma is like it will be the cancer arises from the ducts, milk ducts. Okay. So this carcinoma, it won't spread outside the body. It will be only be stable and only inside of the milk ducts. So only it will be inside of the milk ducts. It won't come beyond to the point or above to the knee. It will be spread inside those particular premises itself. So that is called ductal carcinoma. And we have invasive carcinoma. Invasive carcinoma is same, like similar to the ductal carcinoma, but invasive carcinoma is spread near to the tissues. Means this type of carcinoma which will be that milk ducts like spread to the near to the tissues. Like it is also type of breast cancer, but it will spread to the near to the tissues, like external to that particular breast cancer, like outside of the thing. So that is called invasive carcinoma. The known invasive is spread near to the tissues, like in that particular near to the what are the tissues are there near to that cancer, so cancer cell line. So it will spread automatically to the next to that particular cell or next to that particular tissue. So that's what invasive carcinoma. As sarcoma we already told. Sarcoma is a connecting tissues, like like tissues means automatically fat, muscle, blood vessels. These are all surrounded like bones and joints. As you told, connecting tissues, bones will be connected, joints get connected. So these are all connecting tissues. So sarcoma is a connecting tissue. So sarcoma we have two types. So one is bone sarcoma, one is soft tissue sarcoma. In bone sarcoma, this is the just brief diagram of how this particular, this is the bone osteosarcoma, liposarcoma, so fibrosarcoma. So these are all the general sarcomas which will be connecting. So here this is called connecting. So this is this connecting tissue. So this is this particular, all the connecting tissues cancer, we call it as a sarcoma. In sarcoma, we have five types. So osteosarcoma and chondrosarcoma, this thing, Ewing sarcoma, fibrosarcoma. So these are all called under, because the names will be different, but the thing is like most of the cancers will be in the bone cancer or cartilage or the connecting tissues like spine and skull, backside of the things, our skull and spine. So those are the things. So here attacking the particular cancer cells on the bone or soft tissues in the body, like cartilage. Cartilage means near to the particular knee. We will get some smooth joints. If you want to walk, the cartilage should be good. So good amount of cartilage, so that if something will happen, that cartilage that bone cancer means if the cartilage is completely damaged. So these type of cancers, so which will be sarcoma, like connecting tissues with bone cancer, because sometimes this bone cancer will spread to that particular other cancers like prostate cancer. So it is called, we can call it as the spreading from one organ to another organ, from moving from one place to another place. We can call it as a spreading throughout the body. We call it as a metastasis. So means it will be spreading the cancer to multiple, because sometimes the bone cancer will go to the liver cancer. That if some patient is affected with lung cancer, it may be in future he affected with particular colon cancer or skin cancer. So n number of factors, because we can't even imagine that how the cancer is spreading in the body, that fast it will spread once it got attacked our body, because there will be levels like stage 1, stage 2, stage 3. So those are all things we'll discuss in the next things. So as we told initially, we have a solid tumors and lymphomas. So this lymphoma, leukemia, we call it as this particular, because lymphoma, leukemia, everyone know it is a type of a blood cancer. So it will call the particular tumors or cells, cancer cell forming the blood, and from tissues to it will come to the blood. And types of leukemia. What are the types of leukemia? We have a lymphoblastic leukemia, means like immature cells forming the body. So lymphatic means like immature white blood cells, because lymphocytes is nothing but a white blood cell. So immature white blood cells in the body, so it will be uncontrollable growth. T cell leukemia. T cell leukemia, usually T cell will control the body immune system to fight against that particular natural killer cells, like by outside particular antigen. So if they lose the control, then the tumor will enter into the body and damage the particular organ or the tissue. Then lymphoma, like I already told, it's the white blood cells. It can be few areas like stomach, brain, as I told. B cell lymphocytes. T cell lymphocytes, I told, like it will control the immune system, which can be fight with that particular antigens outside from like a bacteria, virus, everything. B cell lymphocytes, which will be produce antibodies for future. If some diseases will cause to us, so then in future, if the particular disease again came to us, so we have already antibodies, that is called plasma cells. Next time we will go to the particular next slide, we'll get to the things like plasma cell. It will store the antibodies. Once it gets the same virus or same bacteria, same things will come, it will get to fight. So these are normal cells, and these are called leukemia cells. Leukemia cells means that particular leukemia cells. So how that neutrophils, monocytes, platelets, so everything get it multiplied and more get infected. Even the healthy cells became that damage, like this thing, because when the person is cancerous, so if you are taking food like glucose or proteins or vitamins, the complete that particular all those proteins, vitamins will be taking over by cancer cell itself only, because healthy cell doesn't get, but because major part it will be taking by cancer cells, because of that, if the proper normal cell is not getting enough food or particular glucose or anything, automatically like cell is getting to die. So by dying the thing, so it will just take that particular, because then that now, because the power of the cancer cell make that, I told initially, from normal cell to cancer cell. So immediately that cancer cells will take over to occupy that particular healthy cells to the cancer cells. So it will be, that will take huge amount of glucose, so it can utilize those, that huge amount of utilization of that glucose, it will spread to the body, it get energy, it will get move of that thing. So means in this case there will be no, because cell, if basic cell, if cell will develop, then it will grow and it will divide, and it will divide, finally be like a programmed cell death or apoptosis. But in this cancer there will be no apoptosis. So tumor suppressor genes are completely lost their functions. Means tumor suppressor genes, the name itself only saying tumor suppress, means you have to down regulate or down express. But these tumor expressor genes can be modified or lost the functions, there will be no programmed cell death. So automatically there will be growing in the cell, then the normal cell will be grow, and if you, the ultimate will be cell will become die. But in case of cancer cell will be growth, but there will be no particular cell death or apoptosis, because this particular last the apoptosis will be completely lost because of that particular thing. So it will lost, if tumor suppressor genes are completely gone. So because of things, so this cancer will be arranged from the cellular level to protein level, and it will be from metabolism, so it will whole impact on the body. So as I told, myeloma, like this kind of begins in the plasma cells. Plasma are the, I told you, like banks of antibodies, as I told in the B lymphocytes. So it will be myeloma. So here what I am saying, here this is the basic picture. You try to understand. See, this is called TOX3. Means try, because we can call it as a TOX3, or we can call it as a official name, like scientific name for the TOX3 is TNRC9, trinucleotide contain repeating gene 9. So actually, what, when I am doing research on the breast cancer, breast tumors, so what I have expressed is that cancer tumors, like cancer genes like BRCA1, BRCA2. So guys, if you have any doubts, is it fine? Hello. Hello.
Participants, you can ask your doubts
Yeah, I'll
if there
stop
are
here
any.
for a few minutes. If you till now what I was discussed, if you have any doubts or clarifications or confirmations, or if you are not getting the point, you ask me. I will tell you like where what is your doubts. If you have any doubts, you please ask me. You can unmute or you can directly post your doubts in the chat. So yeah, according to you, you can. If you have any doubts, we'll stop, pause for 1 or 2 minutes here. Then if it is fine, then we'll move. Yeah. Okay. Just open the chat here. If anybody want to post or anybody want to ask, you can. Yes, please. So I hope silence. I'll be taking the silence as a completely understanding, right? So then we'll go to next slide. I mean, I will discuss this slide and we'll go to. So what my research, because this is the diagram for this, because every diagram I just kept it as a source, but this diagram I didn't add because this is the diagram which I had drawn from my paper, from my research. So and like TOX3 is tiny protein containing repeat gene. So this is called a particular gene which can be like when cancer is high in the body, BRCA2 BRCA1 genes will be regulate this thing. But when we are doing research, what we observed is TNRC9 TOX3 gene, particularly this gene is more upregulating, and the high levels of BRCA1 BRCA2 genes are for breast cancer. Even this TNRC9 gene have a power to down regulate or down express that particular genes. So that is the power, like where we can identify that if you go into the depth of the concept of cancer biology or oncology, we got to know many things like this. Like this is XOX11 is a transcription factor which will be help more for formation of TOX3 gene spread to the particular body. So it will be move because these alterations or modifications are happened in the genetic level. Automatically, if the because TOX3 is the protein coding gene, because we don't know that when the particular introns and exons will be there, when the splicing will happen, then exons will come, so it become mRNA. So this is the regular concept. It means that mRNA2 will get protein, means translation. So if that particular gene is alterated or modified in the genetic level only, genetic level means then automatically it will impact on the protein level also, because change in the protein structure. Regular TOX3 gene will be structure will be different. When it get modified, structure will be quite different. So it will be changing in the, if you go under post-translational modifications and functional level, metabolically, everything will get it changed. So based on the single alterations of the gene, it will get it changed. So that's what it is. And like main cause of that cancer, I told you, like modifications, everything, mutations. So sudden change in the genetic material, we call it as a mutations. So mutations, we have a number of things like to fibromouracil, and we exposed to UV light. So these are all these mutations. It is a huge concept. So we have a point mutations, shift mutations, like that. But here mostly we will call it as a like point, like sometimes like point mutations will having like point mutations. Sometimes in one chromosome there is a one point, it can be deleted in that particular chromosome level. It will go huge impact on it. Why? Because that particular chromosome is changed because of that particular uh, chromosome get deleted, then it is an alteration. So the function level get it changed. So and like insertion deletions concept. So there at the time like deletion of the particular cell or particular gene in the body, or ATGC, where these bases, if you get it modified, then automatically the particular structure and function will get it changed. So here high level means here in this image, if you go through, if you see this image, these are called just a general phylogeny or general of the particular breast cancer. These are all the gene list which was there in that particular breast cancer genes, are like normal genes. So here if you can see that particular pink color is high level and green color is low level. By seeing of all this picture, most of the cases are which with pink color, like these are all the lines which we need to annotate this. The picture will be slightly different, but it will takes more and more hours to explain. I just want to show you that the cancer, how these particular lines will be and how it spread, like how you take that particular genes. I told you all these genes. So if you take all these genes, we got to know majority of from in the pink color, because cell expression levels will be high. If it is green means it is all we can say it as a normal cells. But when we will take some pictures in the later, because we don't have that picture, so like currently I didn't get that picture. It was there in my other paper, so I don't have a, I will down I mean it is there in my mail, I need to search. So, and when we take after 15 to 20 days, this completely pink color, this completely pink became whole, like we have only 15 to 20 dots of green color will be there, all are pink in color, because within the span of 15 to 20 days the completely cancer is spread throughout the body. Like it will be how much because we have only like 5 to 6 days or 1 week, so it will be spread to within span of that week only, it will be spread throughout the body. So that what it was the cancer is. So whatever the things I have discussed here, so that is just words like understanding the cancer of the in this thing complexity, and co-functioning of the particular genes, and correlations between the genes, and correlation between the proteins, because if the gene is coding into protein, and basic framework. So is there and these are all called, we can call it as expression networks. So how we are gene, this is called as a gene mania, we can write from our internet, and this can we can do it from our research activities. So risk of the cancer, everybody know that age, due to age, and alcohol, smoking, and family having any genes or anything, and that is one part. So here, up to here, we can conclude, we can discuss about the basic functioning of the cancer. So what are the types of cancer, what is the types of tumors, and how the cancer will, what are the mutations, and I've shown it in the figures like benign tumors, malignant tumors, solid tumors, and lymphocytes. So these are all I have discussed till here. Even I told, when we discussed that how it will cause, like alcohol, smoking, family history, due to food habits, everything. These are all come under risk of that particular cancer. So here up to things, this is fine. So up to here, if anybody have any doubts, this is called a basic things of the cancer. If you go to in the next step, then we will discuss about one by one, step by step process. Up to till this is the basic functions of cancer, like oncology. So if you can go into the next topic, so we so far everybody is clear on these concepts, or if you have any doubts, please let me know. I'll be opening the chat here. So if you have any doubts, you can post your charts, questions or clarifications in this box, or you can unmute and you can talk that whatever, if you have any doubts. I'll be just pausing here for 1 or 2 minutes, then we'll go to the next concept. Are you clear on this? Hello? Age factor, yes. Age factor is nothing but a, see, like like if it will be more than 60, 62 years, because of sometimes the stress will also getting cancer. So like during the early age, like like 40, 30 to 40s, so during that age, if the people have struggled a lot, or some pressure, or mental stress, so in maybe future that particular patient, particular man, or particular person may be affected with the cancer. Maybe that will be age after 60, or like near to the 60, or sometimes it will be if the person, because age factor is, that is like old age, it is one factor after 60, and few people who is having the habit of like having alcohol or smoking, so this person will get cancer at the age of 30 to 40s, because of consuming high amount of alcohol and damage to the liver. Sometimes that liver cancer will come. So alcohol and smoking, like lung cancer will come. And also food habits, why I have told you, you asked the like Bimal Khanda, you asked big question, even I missed one point, now I got thing. Even food is also one of the major cancer causing, like like everybody nowadays, we are taking the food from outside, like junk food, or like continue, because the people who are taking, consuming, or take, like they are recurring that particular oil in that particular utensils. If they so recurring of using of oil causes a like cancer in a high level, because the carbon levels in that particular oil will be high. So that is a major cancer, like like in recent statistics show that early age, like young people having suffering with colon cancer, like colon cancer is like the intestine cancer, like food will digestion going to the intestine. So these high amount of taking junk food or outside food, like causing cancer. But for causing cancer in doesn't have age, but if we are maintaining our body, or like diet level, or taking good food, that have matter. But coming to age, if the usually it will take 60, above 60 or 62 based on the person. And also family history also matters, because if the person ancestors having that cancer background history, then it will get affected. But and not 100% sure, if we can maintain a good healthy, taking healthy foods, a good healthy life, then it will won't get. But usually it will take around 50 to 60 above 60 it will get it the cancer. Are you clear? Or I mean, I clarified your doubt, right? Doubt, right? So till now, you have any doubts here? In the silence, I'll be taking as a you don't have any doubts. I thought you are getting that what I am saying, like you are getting the points. So we'll be going to the next topic called we can go it as a medical imaging oncology. So when you are till now we are having we got the cancer everything. So how can you know whether you got detected, where how identified with cancer? So we'll be taking diagnostic tests. So like X-ray, CT scan, MRI, PET CT, so ultrasound, colonoscopy, so mammography and photography. Like photography is an advanced topic. So usually photography nowadays it was not like will be having, but not this thing. Majorly we'll identify in the cancers through MRI or CT scan, PET scan. So these all we can. Based on these only we are getting the things. So this is called as the basic medical imaging oncology. Like we have PET CT, MRI. So these are all the normal regular scans or particular imaging technologies and imaging techniques in nuclear medicine to identify or detect the cancers in the body. Okay. Then we'll go to the particular, this is called a basic thing. So A1, yeah, I mentioned that AG CT. So first CT scan, and this is called MRI, so magnetic resonance imaging. So pure magnetic, and this is called PET image. So PET is because CT is particular a functioning scan, and a PET is a structural scan, because it will move into the different, because it will show only in just single dimensional or this thing, and it will show the particular two dimensional we have rotations. And SPECT image is a particular single photon emission computed tomography. This is called another image which will be in the 3D structure, and it will be more advanced to that particular PET scan. So it will be get into the depth, because here why it is in the orange color, because when usually taking the, if like if if for example if I'm taking I got detected with cancer, I don't like I'm having cancer, how can they identify me? So if I go to the, I'll consult the doctor. So if I go to the consult doctor, if a doctor prescribed me or suggested me go for PET scan. So if I go to PET scan, so they will give me that first of all they will inject me into that FDG, fluorodeoxyglucose. I told you like cancer cell consumes like takes more glucose in the body. So if it takes more glucose, then after I will take glucose through IV, they will give the glucose, that injection they will give us. So if I take rest for 1.5 year or 2 hours, then the whole glucose will spread throughout the body. So it will spread throughout the body. When if you go to the scan, so high amount of glucose where it will be get stored or get occupied. So then based on that scan, they will decide that yeah, okay, where in particular glucose is more stable. Because if it is normal cell, glucose doesn't like, it will store, but a high amount of glucose where it is storing is the matter. So that's what it is. So this is the basic PET CT scan and MRI and SPECT image. So this is the basic things. Like if you go to that particular imaging, you got to know how to identify the tumors in the this thing. And we'll go to that particular laboratory test like biopsy, blood test, urine test. So we have a lot of things. So these are all laboratory tests. We take the collect the samples from our body, urine, blood, and everything. So you know what here once you are affected with cancer, yes, diagnosis, yes, this person is having cancer. So if cancer means there are tumors in our body, okay, means we have because why we have affected like, tumors in the body, that is called cancer. We have, however, we are calculating how we are evaluating our cancer on based on the things. So we have the resist. So resist is the what type of criteria which to calculate of the tumor in the body, on which size it is and which dimension it is, and which diameter it is. So these are all coming to the point. So what are the things, how the tumor size in the body, and how it is what are the things will be there in the body, we can discuss the one by one with that particular steps. So Irano means neuro-oncology studies. So Lugano's, these are called lymphocytes. So PCWG3, this is called for breast cancer. So these are all different type of evaluation criteria for particular cancer patients. If I go to RESIST, so response evaluation criteria for solid tumors, so we can call it as a response evaluation criteria for solid tumors. So this is called RESIST 1.1. This is standardized international guidelines in oncology clinical trials. Like usually it will be in the clinical trials, and how that particular cancer tumors, like cancer, I told you, cancer cell will correct as a tumor. How that particular tumor are shrink, like how will be getting progress or shrinkage. So based on this criteria, we can able to identify all these tumor activities in the body. The purpose of the particular RESIST 1.1 is to outcome of tumor responses in the cancer therapy. So based on particular tumor responses or evaluation, we can go for further cancer therapy, right? So we have the, here we have the lesion. We have call it as a tumor. In medical point, we can call it as a lesion, because I told in biological level we call it as a cell, or we can call it as a tumor. But coming to the medical point of view, we can call it as a lesion. LESION, because that is also a kind of a tumor. With medical language, we call it as a lesion. So now we are coming to the medical oncology. So we can call it as a lesion. So normally, if we have a, we see, if I am identified with cancer, I have the tumor in my body. So then how I can calculate? So whether it is an because here we have few lesions, like measurable lesion, non-measurable lesion. Measurable lesion is nothing but how, how if a person or a doctor or a radiologist or oncologist able to measure that particular tumor in the body, that is called as a measurable lesion. Now, a non-measurable lesion means, like the name itself only saying, we can't even measure, like too small to measure. Like some lung cancers, we have that too small to measure, even we can't even measure. So that is a type of measurable lesions in our body, like when we have a cancer. And this is a unidimensional. So we have a long axis, nodal lesions, non-nodal lesions. So particular nodal points in the body, like cancer cells. So you see, I told you, like non-measurable lesions, like ascites, effusions, bone lesions, we can't even measure. You can ask the question, sir, if you are not measuring the lesions, then how you can identify whether that is a tumor? Like you told that is a tumor, but you are not measuring, then if you get. But the thing is, like if you are not measuring that particular tumor, and in future days, if that particular non-measurable lesion became measurable lesion also, because every non-measurable is too small, even you can't do that. If that particular tumor will be getting grown, or particularly form huge cells, then we can able to measure. Like sometimes, like a lesion will be there, but it won't grow, it will be same as is from still 1 year or 2 years in the treatment. So maybe it will be like, it will be same, like stable in the pit. But if it is a lesion, yes, we are cancering, but once it gets grow, we got to know this thing. So some cancers which we can't even measure, because that is too small, and even we can't even make the calculation of the diameter, like some of diameters in the particular lesion. So usually for this RESIST criteria, we are using CT, MRI, prefer modalities. Modalities means scans, because like what is modality? Modality is nothing but a different type of scan. See, if I have a cancer, doctor prescribed me to take the CT scan. But once I got the CT scan, but doctor is not clear that I am not getting in that particular scan, then go to prefer PET scan. So that is called changing the modality, because sometimes the doctor will prescribe CT. In the CT, the particular cancer or tumors is not clear. Even doctor is not getting the particular thing. So he want to dig more. Then he will prefer go to PET scan or MRI. Then we can get the clarity of particular things. Then we can get the complete details of the particular tumor. So in this image, yes, tumor is there, but we are not getting the clarity or in depth. So go to the another scan. So it will be good. So that is called, we call it as a modality, changing the particular diagnostic test images. And here I told you the lesion category. We have target lesions, we have non-target lesions, new lesions. Target lesions I told, which we can able to measure. Like non-target lesions, like target lesions, non-target we can able to measure. So, but non-target lesions is nothing but a diameter. Target lesions is nothing but a tumor size should be greater than or equal to 10 mm. 10 mm is 1 centimeter. So, non-target lesions is nothing but less than or equal to 10 mm. New lesions doesn't have measurement, so because it will won't form, because like initially it won't be. Maybe during the treatment time or maybe during the clinical trial, the new lesion form. The name it was only saying new lesion, because today there is a cancer in my body. So I have doctor identified one lesion, one tumor in the one place. But next visit after 1 month I came back. I again came to consult doctor. Doctor, this is the situation. When doctors take the CT scan, what initially identified the tumor, we said that there is a one tumor that is called new lesions. So that target lesion is growing, get producing the new lesions in the body. So we, maybe that new lesion will become split, means that new lesion becomes N1 N2, means new lesion 1, new lesion 2. Sometimes that new lesion became completely whole big mass of cancer cell. So this will be like based on the division it will happen. So target lesions, because this is called as a baseline screening, like target lesions, non-target lesions, initially it will be in the screening. As I told, new lesions initially it won't be, but maybe during the treatment follow-up visits we got to know that new lesions in the body. Are you clear so far till now? You are getting, you are getting that what I'm telling? Like you have any doubts, or you are not if you are not getting, please let me know. I will I just taking one pause here, because this is a huge concept and different concept which so if you have any doubts or anything, you please let me know, like how, like any doubts or any clarifications, or if you are not clear on any of the topic or any of the area. So among slides are different to that, like you can ping me or you can unmute and you can ask. I'll be taking 1 or 2 minutes pause here, and then we can move to that next slide, please.
Yeah, participants, the panel is now open to Q&A as well. So any questions or doubts, you have chance now.
So I can take this silence as I don't have any questions. So then we'll go to that next slide. So whatever I told here, right? Target lesions, non-target lesions. So see, this is called I told one like 10 mm, like 1 centimeter. So these are all greater than 1 centimeter, means greater than 10 mm. So here the tumor, see, this is called as a particular CT scan or PET scan. So we can take it. This is a PET scan actually. So this is a PET scan. See, identifying the target lesions. A radiologist will identify the particular lesions in the body, and they will measure the particular diameters like this, like a long axis diameter, short axis. So they can able to measure this one. So and it will, during some applications or during some softwares, they can able to identify that what is the tumor diameter, like 2 centimeters. So it will be greater. They can mark it as a lesion 1, lesion 2, lesion 3. So they can identify how many tumors are there in the body. So how fast it is growing. So doctor will prescribe everything. Even like when we are going to the clinical trial, usually when we are giving some medicine to the particular patient, so if it is monthly visit, if I give medicine to the particular cancer patient on January, and coming to the February, even I'll take the scan and I will look into that same things, like how many tumors are there, like at least how many it was there, and today's target lesions are how many are there. So we can able to calculate, because sometimes during the giving the treatment to the patient, so maybe some tumor get vanished in the body. So that's it. So because ultimately target is like we need to complete vanish of all tumors in the body, then that is the completely cure. So based on the next step, we'll go to that next point, then we go to the next thing. So these are all which this is the actual image of a 72 years old woman for pancreatic cancer. This is a measure, like which we have taken imaging from the particular source. So in one particular journal. So when we are doing work on the breast cancer or anything, so we got to know, and we have this is the just for reference sake I'm telling you, that I have added a source and everything here. So this is a particular 72 years. Yeah, please, Venkatakesh. Yes, please. I will be stopping here. Yeah, please tell me. Somebody has raised a hand. Yes. Can I continue? Hello.
Gauri, you're not audible.
Sir,
if
after
you
massive
want to
growth
speak
of
up.
cancer cells, how to detect particular site we have target? Yes, because see, I told you, initially when we take these things, so doctors can identify able to that particular way that particular origin was happened. See, if you have a, if you take good question, if there are any markers, yeah, we can have that markers. So see, if we go to the doctor and we just consult the doctor, and if he will giving, by taking the scan, based on the scan they can able to conclude that where that particular scan was. Because see, if the particular cancer is moving to the body, like complete the whole the body, and how that origin was started, like where it was started, so it will be looking into that particular tumor, like massive growth in the tumor. So if I'll tell you, I have a cancer in the liver, so it will be moved to the particular intestine. So how in that particular means liver is completely damaged, means 100% of liver, or 90% of liver get damaged, all the most of that lesions is completely filled in the body. Then it will move to that particular spreading it toward the next step, like next organs. So means almost one organ is almost done, 95% of organ is damaged, then it will get it to the next organ. Like once it get it to the one means damage to one organ, it will move to the next organ. So biomarkers are also will be there. We identify that particular normal cells or cancer, because like FDG scan, they use radioactive decay or radioactive fluorescence. Sometimes utilized a biomarker, which, because I told you right initially, FDG, fluorodeoxyglucose. In that glucose, they will add a radioactive material. Means it will be colored. So based on that color, we can able to identify that particular glucose, where that particular cancer cells are more accumulated, and where that particular normal cells. Because radioactive color decay, they can able to identify which is the cancer cell, like, and normal cells, and where that particular cancer cells accumulate of the high amount of glucose get it to deposited. So that's what the exact scenario for that particular scan, or that for that question. So I just, okay, just a minute, I will be sharing again. Okay, I will go to the chat. Okay, sir, I understand the particular site after taking, but other cells also get infected, that will continue. Yes, it will continue. Other cells also, yes, other cells also get it infected, continue. That's what I told you. No, so that other cells, healthy cells, normal cells, everything get infected, because once cancer cell enter into the body, so it will take control, whole control of immune system or metabolism into under that control. So then initial phase 1, phase 2 we can able to control, but when coming to phase 3 is quite, but if you consult doctor early stage means okay, but phase 4 during the time will, because the spreading is high amount of the things, because automatically all the cancer, like normal cells became the cancer cells, so automatically other cells, normal cells, and every cells will get affected once the cancer cell enter into the body. Okay, I have cleared your doubts. Sorry, if immune surveillance continuously eliminate. Okay, immune surveillance continuously eliminates abnormal cells. What is the exact stage that successfully escape the immune system? Immune surveillance continuously eliminates abnormal cells. Okay, and what exact stage transfer? So immune like once it deliver removing of abnormal cells in the like if you have initially if you go treatment in the earlier stage or first 1 or 2 stages, like if the cancer like cells we can able to do radiotherapy, or can able to control it. But if you come in the, that is called, you can you are asking exactly stage like phase moving from stage 1 to stage 2, or sometimes max it will be a phase 2 to phase 3. So if it is, we can able to survive like phase 2 to phase 3, like if we have a very good doctor and everything we can able to. But here the question means first 2 stages we can able to manage, like we can make that abnormal cells or cancer cells make to normal and person become healthy. But if it is like, that is called phase 1 to phase moving to phase 2 or thing. But if it's phase 4 or moving in the last of phase 3, then it will be quite difficult to handle the situation, like based on the person health it will be very different. Can I able to detect the tumor before actually exist? means can you able to detect the tumor before it actually exists. So how like before tumor, like I told you, know, initially the cancer, like you told, you can able to detect before it exists, means you can't able, like, because see, by birth we have the cancer cells in the body. So we can't, because once it get upregulated, once it get highly expressed, then only you can able to identify it. Because if I able to do that particular gene analysis for the particular cancer causing gene, usually it will be like regular normal cell. But when the particular modifications or something happened in your body, that particular cancer cells became the particular cancer cells usually in down regulator position in normal cells. But when it coming into that want to become the tumor cells, it get highly upregulated and like highly expressive. So you can't even before becoming tumor, like you can't, it is not possible. Like the cancer cells will be there, but expression levels will be after that modifications will happen. So then only we can able to identify, or we can able to calculate, or we can able to catch the tumors. So before that we can, because now I am healthy, so like if I am healthy, so I can able to calculate the tumors. Means if I can go to doctor, I can able to, means if I go to doctor and if I ask that genome sequencing or anything, then my cancer cell, the cancer cell, if I take a oncogene, it will become a normal only. But if any modifications happen to the oncogene, then it will become a trigger, and it will express the whole state or a particular country, cancer country in the body. So that's what it is. Sir, will biomarkers, will biomarkers will also able to detect the before the tumor? Yes, before the tumors, yes, it will be able, because biomarkers will be normal and disease cells. If you can able to using microarray technology, it is possible, because the by microarray technology in next generation sequencing analysis, genome sequencing, it is possible, because microarray technology is a technology which you can able to identify the diseases so early. Like microarray, the basic principle is they can able to collect the samples. So they have two samples, like normal, they can use the radioactive decay, everything. So normal cells, how that particular amplifications and duplicates for the they can calculate that one. So based on the PCR or particular microarray analysis, we can able to, yes, this is the abnormal cell compared to normal cell. In this situation, it is not clear. So using microarray, we can able to identify particular tumors. We can act as a biomarker. Yes, it is able to possible to identify before becoming a tumor. Yes, I'll be going to the Gauri Peddi. I'll be going to the before slide. So you please tell me, like, what is your doubt in this slide? Yeah, I opened this. Is this is the slide you're asking, Venkat Akhilesh? Hello.
Uh, Gauri, I think your mic is not working. Kindly use the chat to communicate.
Yeah. I'll be moving to the next slide. So if you like, you can if you have any like doubts, like what is the doubt here, like then we'll move to the next slide. What is the
I think they have some issue with their mic, so
okay?
we can move forward. If
Okay.
they write in chat, then
Yeah,
we'll
then
get
last
back
we
to you.
can discuss the, if you have any doubts.
Yes.
So yeah, so this is called a target lesion. So we can able to see how many, because the n number of tumors are there in the body. So how can you how many you can take? See, max 5 lesions we can take in our from our body. Like whole body you can take 5 lesions. That is be not to that particular to the particular organ. Per organ it will be 2. For whole body it will be 5. So then you can take the rest of things. We can, yeah, we can call it as a target. We can call it as a lesions, but we are not taking. We are not taking not treating under non-target lesions, and we are not taking, because main lesions we are taking, like greater than 10 mm diameter and huge mass of cells. Those takings initially we are taking in the consideration. We are giving the treatment, or we are on the clinical trial activities. So target lesions based on the size and reproductive producibility. So these are all based on the size and reproducibility. They can able to take that particular cancer cell as a like lesion as a target lesion. So that's like some of the diameter get calculated based on the tumor size. So how we get calculated. So some of diameter like uh, uh, this thing like 5 of 10 mm greater than 10 mm, how many are there? So out of 5 lesions they can able to calculate the diameter, and they can able to produce that the sum of diameter is this thing. So we can able to need to reduce that particular region in the body. So like with greater than 10 mm or 15 mm or 25 mm, so it will be gauged on the calculated diameter, then you got to know that. So non-target lesions is not for as per target lesion. So this is because this is non-target lesion. So this is completely different. And Baytran stages, follow-up stages, that non-target lesions become will be target, means they can be greater than high mm in the diameter, and new lesions will be formed in the follow-up visits as we discussed. So this is called as the image of the particular baseline study, because see, complete response means completely that particular tumor is vanished in our body. This is called this thing. And partial response is nothing but 30% of reducing the particular tumor size. So stable disease means nor partial nor growth, means it will be stable. Progressive means greater than 20% of tumor size, and minimum 5 mm in the particular tumor, like at least 5 mm. Overall it will be 20%, 20 mm, but minimum 5 should be the maximum. So if this is growth levels, if this tumor is completely vanished in the body, means healthy, we can call it as a complete response. Means compared to previous visit, this visit the tumor is reduced to 30 less than or equal to 30 mm, then we can call it as a partial response. If last visit it will be 15 mm, this visit also 15 mm, we can call it as a stable disease. So last time it will be 15, this time it will be 30 or 45, then we can call it as a progressive, means tumor size increasing. In our ultimate objective and primary endpoint or primary thing is like we need to reduce the tumor size in the body. So that is the ultimately goal. So this is what I discussed: 20% increase, 30% reduce in the diameter. So nadir is if in the month of January the tumor say, for example, like nadir is simple example I can give. Like nadir is like in the month of January my tumor size is 30%, and coming to the February my tumor size is 20%. So means 30 to 20 it got reduced, but in into the March the tumor size will be increased again to 60. That is called nadir. So we need to calculate the particular nadir calculations according to that particular tumor size. So that's what it is here. Progressive, stable, nor PR nor PD. So that is in non-target lesions also same thing, like less than or equal to tumors is completely vanished, non-CR or non-PD. See, this is called as a PR or stable, like it won't get it into the progressive level or complete response. It will be stable, like stable disease, like tumor is not growing or not suppressing, it will be stable. So progressive disease. So these are all progressive disease, unequivocal progressions, nodal lesions. So more expressive things we can call it as a during this progressive disease. And we have because I told you, right, this is called up to resist. Up to here you have any doubts? Resist. You have any? Up to here you have any doubts? So the silence I'll be taking as a no doubts. So I'll be moving to the next slide. So this is called RANO, like neuro-oncology. What are the things we are calculating in the breast cancer or lung cancer? Same things we can do it in the brain cancer, like same type of things, target lesions, non-target, new, everything will be same. But criteria will be different. So based on the particular tumor, based on the particular patient, so we can able to do that. Lugano and these are all called, we can call it as a lymphoma studies. So here the tumor size should be greater than or equal to 15 mm. In the resistant rano it will be greater than 10 mm, but in tumor, in lymphoma it will be greater than 15 mm. Lymphoma we got to know leukemia lymphocytes. That's why we can have a B lymphocytes. So Hodgkin lymphoma, non-Hodgkin's lymphoma. Hodgkin lymphoma is having lymphocytes of malignancy rising from B lymphocytes. Non-Hodgkin's means lymphomas arising from B lymphocytes, T lymphocytes, and natural killer cells, because these are all the lymphocytes which will be fighting with foreign bodies or bacteria, viruses in our body. If these called suppressed or these called these cells only the cancer cells are producing, then you can able to think of it like how that cancer is spreading, because B lymphocyte, T cells, natural killer cells are the particular core fighting cells in the body. If these called affected with malignancy, then who will fight? There will be no nothing fight with it. So we need, so for that type of things, because see, initially I told we need to, based on the genome sequencing also, we can able to identify that particular disease, like initially during like before going the treatment or initial stage without cancer also, we can able to identify like how the cancer cells will be. As one of the member in this group asked that is there any biomarkers or anything, I told I think able to detect this thing like Chandel. So she told like this is called biomarker discovery. So here we can able to precision medicine. So these are all coming to the pictures. We can able to identify disease before that. Even in currently now you can go and you can do the samples for genome sequencing. They can able to measure the based on your cellular activities levels, sequencing in the variation in the regular cells, genetical modifications or genetical mutations. So they can able to measure that particular in future maybe this particular person is affecting the cancer or not. It will be possible. And biomarkers, I told, identify genes, proteins, cancer sickness, getting control of abnormal status. So these are all one like biomarkers, which I told the same thing only will be there. We're using microarray technology or RNA-seq technology that will be doing from that particular hospital diagnostic centers they can do, because nowadays they have a lot of aware of cancers. So this is called biomarkers. And we have the last topic is surgery. Still now you have any doubts here like biomarkers, genome sequencing, and like these things. If you have any doubts, then we can go to the therapies one or two. Then we can able to conclude the thing. So if you have any doubts, so we can able to this thing. One someone has been. See, complete recovery, see, particular thing, you ask a good question, Angana Chaudhary. So, see, we have a lot of technologies. We have, prescribable latest technologies, NGS technologies, microarray technology, like whole genome sequencing technology. Why you can't able to identify, why you can't able to, sorry, not able to, like, we have a, why you can't able to cure, even many therapies are there. Yes, I agree with you. Why? Because, see, like cancer, because the people having, like, awareness is there, but people are taking, like usually some factors like genetic factors during the early stage, like people are not taking the detecting the early stages, like like people will be like, because see sometimes like there is a cancer in our body, but there will be no symptoms. Once its symptoms get come out from the body, then we got to know that there is something happening in our body. But when symptoms came outside from the body, then the body particular tumor or particular disease is rising almost done from our body. So that's what, like awareness is there, but people are not going to regular checkups, or like we can able to take. And that is the one point. Another point is like during early stages when people are suffered a lot during work tensions or pressures, everything. So maybe in next level it may get it cancer. So like during stress or pressure, take
Sir,
not. Okay. Hello. Hello. Hello.
now I am audible, sir.
Yeah. Yes. 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 You are telling. Yes, please.
Sir, actually, I have doubt in the previous month. Unable to ask
Yeah. Yeah.
due
Please.
to microphone issue.
Okay. Okay. You mean this one? Let me. This one, right?
Before slide, sir. This one.
This one.
Next,
This
this
one.
one, sir.
Yeah.
TL and NTL.
TL, yeah, target lesions is nothing but a target lesion is nothing but a lesion is a tumor. Target lesion nothing but a, it is a like a tumor size, means cancer cell size is greater than or equal to 10 mm. We can call it as a target lesion. And NL means non-target lesions, means this cancer size, that is also cancer, but we are not calculating, or we are not targeting that particular things, because non-target lesion tumor size is less than or equal to 10 mm. So that's what we did, because usually when we are calculating the tumors in the body, we'll consider it as a target lesions. Even we can mark it as a non-target lesion, but primary objective is like not target lesions, because the name itself when is saying that these are high mass cells or high amount of huge mass of cells and highly growing cells, we can consider it as a target lesions, and we are first targeting those cells, then rest of things also cancer cells, but step by step we are coming. So that's when we can call it as a target lesion, nothing but a tumor size is greater than 10 mm. So we can call it as a target lesion. And new lesions means during our follow-ups and giving treatment, sometimes new lesions will form, like based on cancer. See, if even I am taking medicine, even though cancer is there in my body, if I am taking medicines, there is no rule like cancer is completely getting suppressed or controlled. Maybe yes, even I am taking medicines also, I'm getting new lesions. That is the things here. Like within taking 1 month, using 1 month or 2 months of medicines, completely whole cancer will won't get it cured. It will take a lot of years to cure that one. So that is during that time, during treatment, maybe yes, new lesions will form. So that's what it is. You
Sir,
got the yeah.
actually not target lesions and non-target lesions are defined in the baseline or screening. L would be metastasis upon follow-up visits. It is
Yeah, because see, why? Because target lesion, non-target lesion, baseline means, see, I'll tell you, if you are the patient, or if, see, think I am the patient. For example, if I am the patient, I am affected with cancer. If I go to the doctor and he prescribed this PET CT scan, I went to the scan and I got the scan. Then doctor able to identify tumors like in the body. I told you like initially 10 mm less than or equal to greater than or equal to 10 mm. Based on the tumor size, he can able to identify, because before giving the treatment we can call it as a baseline or screening. Means we are able to taking as a eligibility whether this particular person is having that particular tumors in the body. So during that screening level they can able to identify the target lesions and non-target lesions, because lesions are there only now we can get it scanned. So that's why these are identified in the screening. New lesions won't be in the screening level, because see, what are the things are present in the baseline, those are we'll call it as a things like we can able to, if which is the tumor not there in screening or baseline, we can call it as a new lesion, because during our screening level that particular tumor is not there. Later on stages the new tumor got produced in the body, then we can call it as a new lesion. Why? Because if we compare with the new lesion scan with earlier scan, yes, this tumor is not there in my body. Now in this because in January I took scan, I don't have, but in the month of February or March I took scan, yes, new lesion is there in my body. Yeah, based on the reference we got to know where these things. So that's what it is, the general or basic difference between the new lesions and target and non-target lesions.
thank
I mean, yeah,
yes, sir.
you got clarified, or
Metastasis means
metastasis means like like cancer is spreading from one organ to another organ. Metastasis, meta, many. So many, we can go it isn't multiple, because today I am affected with the liver cancer. Maybe after 1 year or 1.5 year, body will be moving liver tumor or cancer will be moving from liver to intestine, or liver to bone, or liver to pancreas. Look, that is called metastasis. Cancer is multiplying, affecting the multiple organs in the body is called metastasis.
okay, sir. Thank
Yeah,
you, sir.
yeah, no problem. Yeah, yeah, okay, okay. Then we'll go to the uh, here. Like, see, these are all the different cancer therapies. So we are see we are discussed the basic things of cancer, and we have discussed the how to evaluate the cancers. So now what is after evaluation? How can what are the treatments? So we can give the treatment like chemotherapy, radiation therapy, target therapy, surgeries. So many things are there. So we'll discuss just like we can, because we passed the time. Sorry for that. So we are discussing the surgeries here. So different type of, see, surgeries, because see, if the initially if the particular tumor is there in our body, or during the phase 3 or anything, cancer initially stage we can able to cure by using surgery. We can able to do the surgery and remove that particular cancer, and after that we can do the treatment like radiotherapy. Max doctors and everyone prescribe go to the radiation therapy using high energy sources. We can able to kill the cancer cells, but chemotherapy we can, our body immune system get affected and lot of side effects will be there, and the cancer like taking high amount of huge amount of drugs and huge amount of medicines and intravenously. Chemotherapy is a hardest thing in the giving in the cancer treatment. Like even sometimes during chemotherapy, the patient able to can't even survive because of chemotherapy. Some patients will be passed away because of that is the reason, because the body immune system can't able to support to that particular treatment. So max doctors try to 100% to cure during surgery or radiation therapy. But during the many technologies, and we can doing a huge research on the thing, we are using target therapy, hormone therapy, and we have immunotherapy, and we have bone marrow therapy. Like many therapies are came, means then we can able to skip these particular type of sometimes chemotherapies with patient having, because doctors and scientists and we research, we always do the things we need to cure the disease, not too much stress or too much pain to the patient. So in that point of view, we have a targeted therapy, means we are able to target in particular genes or molecules responsible for that particular growth. We are giving some particular medicine or particular therapies or treatment, or using x-rays. So we are using only focus on the particular areas there that particular cancer is originated. So we are using target therapy, and these are all the images like chemotherapy, radiation therapy, hormone therapy, stem cell therapy. So immunotherapy is we are not giving any like we are able to stimulate the immune system using some some not high power medicines or normal medicines or normal treatment or normal general medicines. We are able to stimulate the particular immune system to food or to initial things. So we can able to use up immune therapy, like genetically modifications also, like using CAR T cell therapy recently we are using. So these therapies we can able to, doctors are giving these type of treatments. So hormone therapy, remove the hormones in the body, inhibit the growth of cancer, because some hormones will thyroid, if thyroid is there, like we can able to remove that particular thyroid hormone in the body, then it will eliminate, because initially it won't be that type of things. So later on stages technology we can able to particularly remove the particular things. This is also come under different type of therapies. So stem cell or bone marrow therapy, see stem cell therapy make it produces we can giving some providing make that particular replacing of healthy unhealthy cells to healthy cells, or we can able to take that bone marrow or like plasma cells from another one patient to another. During COVID time we can go to know that plasma donor of the plasma, same type of in the plasma we have a fighting effect with the cancer. So during that bone marrow, like stem cell or bone marrow, so both are almost same. So we can able to donor of the plasma. Then if the particular plasma is injected to the cancer patient, maybe that particular antibodies or particular things may be fight with the cancer, or just to control the cancer in the body. So these are all the basic type of therapies. And CAR T cell therapy, because we have you can take in a particular cell which is able to external, we can give injecting a normal outside, like this thing like radioactive, a type of radioactive cell or general cell injecting into our body to able to identify and to suppress that particular cancer genes in the body. Like this is a new technology which immunobio company from Maharashtra, Mumbai, I think so. So they are done very pretty well in the developmental of CAR T cell therapy. Even many things will be going on. Even some people will be using CRISPR-Cas9 technology for genetic modification, genetics, like genetic editing. So these are all the new technologies which will be these things. So recently we have, not even recently, like years back, we have a medicine for cervix cancer, like HPV medicine of 14 and 16, like amino acid number 14 and 16. So these are all the, like we have plenty of vaccines technology will be there. So based on this therapy we can able to design, based on the target therapy we can able to design the vaccine based on the things we can able to provide the medicine to that thing. And precision medicine will be there for each and every cancer, because in that in the cancer treatment, every patient doesn't have the same treatment. Patient to patient treatment will be different. This is called, we can characterize a precision treatment based on the person other health chronic disorders like diabetes, heart problems, or blood pressure. The treatment will be person to person, it will get it vary. So that will be providing by doctors, and medicines also will be doing clinical trials, will be able to see all these things into the consideration. So this is all the therapies and treatments for the cancer. Yeah, if you have any questions, we got concluded. So if you have any questions, yes please, Venkatakilesh.
Sir, in which comes like your stem cells, it is a pluripotent or totipotent stem cells, sir? Which
Pluripotent
type of,
cells.
sir?
Pluripotent stem cells.
Pluripotence.
Yeah.
Okay.
So multiple, like many stem cells like pluripotent, multipotent, many things like mostly pluripotent. It will take like multiple things like multipotent. So based on the things, it will they will take into that stem cells. So these things, because stem cell concept, because stem cells, if you go to the depth of the stem cells, so stem cells is nothing but where the particular organ is originated. Like recently, in US or UK, that is a huge cost of project. If you target that particular stem cells, because cancer cells are originating from the, because where organs are particular originating, where if you target those particular stem cells in the body, cycle wheel chain concept. If you can go to the cycle wheel chain concept, in central there will be wheel will be there. In that, from that particular wheel, there will be spokes which will be attached to that particular rim. So that is called, if the particular center thing which will be rotating, we can call it as a stem cell. What are the spikes or spikes which will be attached into that particular rim, we can call it as a cancer. See, one spike is a lung cancer, one spike is a liver cancer. So you can originate, or we can target that particular origination, then we can able to cure. But targeting of the stem cell therapy, or targeting, or doing a research work on stem cell therapy is quite a bit difficult, and it is a like high cost. Like people are doing in some other way to reach out that particular what a exact thing will be like able to cure that. Yes, that is the things, like we can take the that is what the stem cell therapy is, like multipotent, pluripotent, that is like cells will be taken from the body. You got that out? I mean, clear to your doubt?
Yes. Yes,
Yes.
sir. Thank you,
Okay.
sir.
Got it. And do you have any questions? Then any questions or anything? I'll be opening the chat here, or you can unmute and you can ask the questions.
So I have one question.
Yeah, please tell me.
So many therapy shows great result in preclinical studies but fails during clinical trials. Like
Yes.
from your experience, what usually causes this gap? And how can future researchers design studies that translate better to patients?
Yeah, because see, preclinical trials we can do it on the mouse or anything, because preclinical is nothing but we can do the mice or mouse anything. So coming to the clinical trials, that is called real things. Like, because see, clinical trials, every patient is not clear. Sometimes the patient is already, the patient is affected with cancer. Cancer patients only will take into the trial. So based on the health conditions, and if sometimes you see, I am there, the particular cancer drug is given to me. Maybe that particular got a highly affected to me initially. I got particular, I went into the coma, and later I became into worst. So, but that particular drug which I was taken, that will be work for you. So that is the thing will be. So at that time, what are the other medicine, like a convents we are giving to that particular things is the matter. Like in future, you are asking that based on the things, how we can able to cure. Yes, using these lots of technologies, and like all these therapies. I told you about the genome sequencing and microarray analysis. So initially, before initial stages, and we can able to, based on the family history, even you can able to go to the doctor and you can consult doctor whether, see, my grandfathers or my ancestors having cancer. Maybe if I get a cancer things, we can able to get genome sequence. You can able to give the samples, then they can tell you whether that particular cancer will get it or not. So based on genome technology, that will be possible. But that is a huge, like many, like nowadays many hospitals are introducing that particular test or the things, but initial stage it was not there. That's why more people get affected and got, unfortunately they got died. And during clinical trials, we are giving multiple therapies and the things, but maybe sometimes body metabolism won't support. Maybe that clinical trial, a drug or a vaccine that we are taking, that is not, it will get affected. It will show some adverse events, and even if you use some converts also, it won't be slow down in the process. So that's why the people are getting died. But nowadays people are more aware of the things and going to the genomic studies, and initially going to the doctor and taking the things like whether maybe in the future I'll get the cancer or not. And if a person unfortunately get affected with the cancer, so they are going into the doctor initially stage, taking the proper medicine and food to get cured. And for ladies, especially women, so after at the age of 40, better all the ladies nowadays, like initially it was not there. And like 40, at the age of after 40, most of the women will go for mammography, which initially that I just dropped in my slide, like mammography for identifying the breast cancer in the body. Like during the last of the like during the early stages, old stages, like above 50 or near to 50, women will lose the period. So at that time, maybe the breast cancers like during the like immune system or metabolism. So sometimes so better after 40, most of the women nowadays they are going to the doctor and taking mammography whether it got affected or not. So that's what it is. Like earliest you can ask the question like earliest why the cancer is not there. Women can earliest like women won't like earliest stages like like nowadays also it was there. Why women breast cancer will come like this thing. So like not only the food or any stress or anything, but also like like what are the when we are cooking that everyone right like pope like when you are doing cooking some pope that type of things, even that type of things also enter into the body, it will get cancer. So that's what it is. See,
Okay, sir. Thank you.
yeah, and Angana Chowdhury asked the question like immune checkpoints inhibitor, how can the cancer cell escape? See, immune checkpoints affected because cancer, if you can check immune checkpoints inhibitors, even though also that if it is the cancer, because I told you it will get modified. See, same thing like if you get modified, immune checkpoints have something like even able to this type of like checkpoints which able to identify. If a cancer is getting masked or just modifications or alterations, it will get even that will be easy to escape that particular checkpoints and it will be enter into the another organ or connective tissues. So once it gets spread into the things, it won't able to control with the antibodies or antigens. It will be because time to time it will change. What are the cancer is there in my liver cancer, that will be different cancer only, but structure and function will be different. So my liver cancer cell, there is a in my cancer there is in my liver there is a cancer, so it will function in some other way. Same cancer cell went into the brain, it will function in a different way. So it will see how it will be escaping to see from entering into the organ to organ only inside, how it will be escaping. So once it gets, so that is the thing, it will be masked based on modifications, it will definitely escape from the checkpoints. So that's why we are taking the checkpoints. We can able to target. That's why we are taking the target therapy, or target medicine, precision medicine to activate or to growth or to hide that particular inhibitors, cancer inhibitors, to stop that particular growth in the body. Yes, exactly. A good question. Can I clear? I have clear. I understand. Okay. Okay. Thank you.
Yeah.
Uh,
So
yeah.
thank you very much, Mr. Ravi Teja, for this insightful session.
Yeah.
We would have to stop the Q&A session temporarily for now. I have shared the email address here for other students who have some follow-up questions, because there are some people who also go through the recordings of our sessions as well. So they will watch those recordings, and then there are any doubts, then they can come out, reach us at biopractify@gmail.com.
Excuse me,
So,
Sure.
sir.
Yeah.
Can I ask the last question?
Yeah. Sure.
okay,
Please.
then one last question.
Sir, whether bioinformatics plays helps in cancer therapy or oncology?
Yeah, bioinformatics based in the like cancer oncology or cancer therapy, like both are these things come under oncology and cancer. These things in scientific name we can medical point we can call it as oncology. In biological or pharma we can call it as yes. Bioinformatics plays it because I am from MT. I also done from I am from masters in biotech bioinformatics. So I plays because bioinformatics plays a key role in cancer biology. I told you right initially, microarray technology, RNA-seq data analysis, whole genome sequencing. These are all the crucial points or crucial studies in bioinformatics. If you want to know all these things, you know to want to know about the bioinformatics data analysis, and how that particular biomarkers will be there, PCR. So all these because it is a huge concept, RNA-seq and these things. So if you can go through the bioinformatics, can yes using you can play a good role in cancer therapies or cancer treatment or in the cancer research. That is a good thing. Even because I studied bioinformatics and I learned the things and I am doing in the cancer studies like it is breast cancer or colon cancer or brain cancer, so like that. It's
Whether
a
it
good.
is easy for like basic zoology post graduation
Yeah, it will
students?
be easy only. Like I see, programming part will be there, but that is not too much difficult. General small programming like R, Python will be there. That huge, not a like a computer science or a rocket science. It will be huge easy. So you can go through it. This thing that is easy, but you can once if you can. I mean, after your graduation or if you're masters like post graduation, if you want to willing to go to the PhD, or if you want to willing to go for further research activities in cancer, or if you want to do other PG diploma in cancer, so it will like by PG diploma in bioinformatics, it was a good like it will be like even non-biologics, non-bioinformatics background also, even you can go and shine it in that particular field. It was good, no
Okay,
doubt
sir.
at all. I'll assure you.
Thank you,
Because
sir.
yeah, even I came from some mathematics background. Even like few things completed non-biological. I came into the mathematics. Then I learned everything. Like it will be easy only. You can have a number of guest lectures will be there, tutorials and teaching. So by going through the reading books, papers, so it will be easy. Nothing too much worry about it. It will be easy only. Yes, exactly.
Thank you, sir.
Yeah, no
Yes,
problem.
and you can also check out beginner-friendly programs at Biopractify.
Yeah, sure.
Yeah, so as we come to the conclusion of the today's session, I would really like to extend our heartfelt gratitude to Mr. Konduru Somanadh Ravi Teja for delivering such an insightful and well-structured talk on an overview of medical oncology and therapies. And thank you, sir, for sharing your valuable industry experience, research insights, and practical perspectives from the field of clinical data and oncology. And your session has truly helped bridge the gap between academic understanding and real world clinical applications, which a lot of students rarely get to access to. And it has been immensely beneficial for our participants as well. And we are really thankful for you to take this on such a short notice. And we would also like to sincerely thank all of our participants for taking the time to join us today, for your active participation and making this session furthermore engaging and interactive. And